Good morning. It's 7 o'clock. You can start the presentation.
Yes, sir. I'm sharing, sir. 1 second, sir. Sir, the meeting ID passcode is coming as a wrong passcode, sir. I'm not able to log in from my laptop, sir. I'm just trying. 1 second, sir.
Okay, no issues. Pros and cons of what has happened. So attend at 5 o'clock. I hope everyone will be able to attend. We don't have any important OPD during that time. Please attend the meeting.
Sir, is my screen visible?
Yes, it is visible. You have to mute one of your mic.
Yes, sir. 1 second. Hello.
Start, Govind.
Yes, sir. Sir,
We are not able to hear you.
sorry, sir. So today I'll be starting with the clinical evaluation of shoulder pathology, the ortho-one template and recent advances. I'll be going through the ortho-one template, and I'll be basing my presentation on the same format. So first, on any shoulder case, we'll have to start with the proper history to get to know the basis of the pathology. And on the examination part, we should start with on the general aspect on the inspection, starting with the shoulder contour, and to look for any wasting in the infrascapular and suprascapular fossa, the deltoid, and for the scapular movements. And we should also look for the Baton score of the generalized for ruling out generalized laxity. And On the palpation part, we'll start with the AC joint for looking for tenderness, and the Codman's point, which is the insertion of the supraspinatus tendon with the shoulder in extension and internal rotation. That will be the best point to palpate the Codman's point. And the we'll also palpate for the coracoid biceps tendon, and the anterior joint line will be just lateral to the coracoid, and the posterior joint line, which will be medial to the posterolateral border of the acromion. And after finishing the inspection and the palpation, we should there are special tests in shoulder examination which I will be focusing on, and I will be going through the special tests as per the order of the ortho-one format, and I'll be adding some extra tests also and talking about them. First, coming to the rotator cuff test, the testing for the supraspinatus. The first test that we all know is the empty can test, or the Jobs empty can test, where the patient is seated upright, and the arm is brought to 90 degrees of abduction in the scapular plane, and in full internal rotation. And the patient is asked to raise the arm, where the patient not being able to raise or pain is a positive test. The full can test is the same with the hand in external rotation, the arm in external rotation, thumb pointing upwards. And the full can test has been shown to be less provocative when compared to the empty can test. And the toes test, or the sign, where the as you can see, the patient's arm is held in 30 degrees of abduction with mild external rotation, 30 degrees of flexion, and 90 degrees of elbow flexion. And we try to push down the arm while holding at the elbow, just above the elbow of the patient. We try to push down the arm, and the patient is asked to resist. Not being able to resist or the arm going down is considered positive. And this is another photo showing the champagne toe sign. The first image A shows the pore sign, pore position, where the arm is in 30 degrees of abduction, forward elevation, and 90 degrees of flexion at the elbow with mild internal rotation. And we usually test at the toast position, where the arm is at 30 degrees of abduction, 30 degrees of forward elevation, and 90 degrees of elbow flexion with a mild external rotation. So this is a study published in Journal of Shoulder and Elbow Surgery in 2016, showing that the champagne toast position isolates the supraspinatus better than the Jobs test. And this was based on an EMG study looking for recruitment of the surrounding rotator cuff muscles as well as the surrounding shoulder supporting muscles, which showed that the isolation of supraspinatus muscle was much better in the champagne toast position. Next is the drop arm test, which we all know. The patient is asked to abduct fully, and on the eccentric of the passively we abduct the arm above the shoulder for the terminal abduction, and the patient is asked to lower the arm down, and during the eccentric part of the motion, patient won't be able to bring it down slowly. There won't be a controlled drop, and the arm drops down without the patient being able to hold it. This is more suggestive of a full thickness tear. And this is a study showing the diagnostic accuracy of special test for rotator cuff tear for the supraspinatus. This study has covered the accuracy for all the tests for the rotator cuff tear. This slide showing the supraspinatus efficacy, whereas the Jobs test has a sensitivity of 80% and specificity of 62%. The full can test, the empty can has the same 82 and 62, and full can has 70 and 81. So specificity is more for the full can test. And the drop arm test is highly specific with 96% specificity for there being a tear. Next, we'll go on to the subscapularis test. First is the bear hug test, where the examiner places the hand of the affected side, the patient's hand on the affected side, to the opposite normal shoulder, and asked to press down using the arm. So, and the patient and the examiner tries to lift off the arm from the patient's opposite shoulder. So, if the if the examiner is able to easily pull off the arm from the patient's opposite shoulder, then that means there is a subscapularis tear. And next is the Gerber's lift-off test. As shown in the picture, the lift-off test is performed with the hand being held in internal rotation in the mid-lumbar region. And in this position, the other internal rotator muscles, the pectoralis major, is not recruited and there is minimal activity of that muscle in this position. And this test is supposedly it isolates the lower part of the subscapularis. And the next is the belly press test. This was also described by Gerber et al. And you can see in this position, the patient is asked to press upon his belly using his hand. The points that we should note during this test is there are ways in which the patient compensates when there is a subscapularis palsy. One is by flexion of the wrist. The patient presses by flexing the wrist onto the belly. That is called the Napoleon sign. And the other way is ideally the elbow should be in front of the body because the patient should be pressing with the wrist in neutral position using the internal rotation action of the shoulder. If that is not possible, the patient actually presses with the extension of the shoulder and the elbow goes backwards beyond the plane of the body. That is also considered a positive test. So we should make sure the elbow stays at front with the wrist in neutral position and the belly is pressed inside. This again is uh, slide showing the sensitivity and specificity of test for the subscapularis, and the most specific test is the lift-off test, and the bear hug test is the least specific test. But the sensitivity is more for the bear hug test. Next, coming to infraspinatus and teres minor. So before going into the test, I just want to stress upon the fact that the infraspinatus primarily acts with the arm in neutral position, whereas the teres minor is more active with the arm in external rotation, 90 degrees of abduction. So the test also will depend upon that. The first is the hornblower side. So in this test, the patient is asked to abduct and internal rotate. A patient's arm is in abducted to 90 degree, and the elbow is in flex 90 degree, and it is in internal rotated position, and it is held like that, and the patient is asked to external rotate against resistance. If the patient is able to external rotate against resistance in this position, it is if she is not able to external rotate in this position, it is likely to be a teres minor tear, because in this position the muscle that is recruited more for external rotation is the teres minor. Next is the resisted external rotation test, where the patient is asked to keep his arm by the side in neutral position and then asked to external rotate against resistance. And in this position, the muscle that is recruited more is the infraspinatus. And next, the lag signs. We usually test rotating of muscles in two ways. One is by asking the patient to do the movement up to the maximum range. The other one is passively making the movement for the patient and asking the patient to hold the position at that point, if the patient is able to hold it or not. These are the two ways in which we usually check the rotator cuff muscles. And the lag signs, which are described by Huttel et al., are the signs in which we do the movement passively for the patient till the end range of movement and ask the patient to hold it there. So the first is the external rotation lag sign. Next is the drop sign. And the external rotation lag sign is done by, as shown in the picture A, the elbow is passively flexed to 90 degree and the shoulder is held in scapular plane, 30 degrees of forward plane, and the near maximal external rotation without stretching the capsule is done. And at that point, the patient is asked to patient is asked to hold the position after we leave the patient's rest. If the patient is able to hold it, there will be some lag as the patient's external rotation power will be less. The patient won't be able to hold it till the end point. There will be some lag in the range of movement. So that is a positive side. This is also showing the same test. The patient's arm is held in near maximum external rotation, and the examiner leaves the arm. Then the patient's arm goes for internal rotation. It lags down. That is a positive sign. Next is the drop sign. Here also the affected arm is held at 90 degrees of elevation in the scapular plane and almost full external rotation with the elbow at 90 degree. Then the patient's arm is let down and then it actually falls down. It drops down. That is also a sign of weakness of external rotators of the shoulder. Next, the sensitivity and specificity. The specificity for external rotation lag sign at 90 degrees 100%, and the sensitivity for all these tests are very low. Only the specificity is more. For the Hornblower sign also, the specificity is at 96%. Next, coming to impingement test. First is the painful arc. The painful arc means when the patient is asked to abduct the shoulder, the patient experiences pain only between the ranges of 60 to 120 degrees of abduction, whereas the pain reduces. Once the arm goes past the 120 degrees of range of abduction. So this is suggestive of a subacromial impingement. And the sensitivity for this is 33%, specificity is 81%. The next is the knees impingement sign and the impingement test. So the first impingement sign is when the patient is asked to hold the arm in forward flexion up to 90 degree in internal rotation, and then we passively raise the arm. If the patient experiences pain in the subacromial region, that is suggestive of an impingement. And for the test, we inject silocaine into the subacromial space to see if the pain subsides completely. So if that happens, then it's a confirmatory test. Next sign for the impingement is the Hawkins test, Hawkins-Kennedy test, where the patient's arm is brought to 90 degrees of forward flexion, and elbow is kept in 90 degrees of flexion, and then the examiner stabilizes the scapula of the patient, and then internal rotates the arm. So again, it reduces the space at the subacromial region, and if there is a impingement, the patient will experience pain. Here, the sensitivity is going up to 92%, and the specificity is high also. Next, the test for different test for slap lesion. The slap lesion has many tests have been described for slap lesion. First is the O'Brien's active compression test. This was described in 1998 to distinguish between the superior labral slap lesions and the AC joint abnormalities. So the test is considered positive. Initially, the patient will be asked to forward flex the arm in extension and then internal rotate. And then we'll be giving a resistance, and the patient will be asked to elevate the arm against resistance in internal rotation. So and then on the second step of the test, the patient is asked to supinate the arm in the same position and then elevate it. So one in internal rotation and the one in external rotation. They'll be asked to raise the arm. So the test is considered
Govind, we are not able to hear you.
sorry, sir, I got a call from the board and it got cut, sir. Sorry.
Yeah, proceed.
The O'Brien test has two parts. One in so I was describing the two sections of O'Brien test, and if the test is considered positive, the pain was elevated with the first maneuver, that is in internal rotation, and was reduced or eliminated with the second one, that is in supination or external rotation. And this is a small video of the O'Brien test. The video is not working, so it is showing the same video with the arm in internal rotation, then in supination. So we'll move on to the next slide. It is the modified dynamic labral shear. So this is another test for slap lesion. The examiner flexes the patient's elbow to 90 degree and abducts the arm to 120 degree while maximally externally rotating the arm. While placing the arm into maximal horizontal abduction and maintaining the external rotation, the examiner lowers the arm to 60 degrees of abduction from the 120 degree. Positive test is occurs with pain and painful click along the posterior joint line between 120 and 90 degrees of abduction. It is difficult to understand with just by saying, so I added a video. I'll just see if it's working, sir. The videos don't seem to be working, sir. It was working till now.
No issues, no issues. Proceed with your talk.
Next is the crank test. This is again a test for the slap lesion. The patient is in upright position with the arm elevated to 160 degree in the scapular plane. Then at that position, the joint load is applied along the axis of the humerus from one hand of the examiner, where the other hand performs the humeral rotation. So we are basically rotating the humeral head into the glenoid with a force applied along the long axis of the humerus, with the arm held in 160 degrees of elevation in the scapular plane. This test is positive if there is a click or when the pain develops while we are doing an external rotation, internal rotation of the test. Next is the anterior slide test. Patient places their hand on the hips with their thumbs pointing posteriorly, while one of the examiner's hand is placed across the top of the shoulder. So we stabilize the shoulder from the above. We stabilize the scapula, and from the patient is asked to push back with the arms held at the hip, with the thumb facing backwards. And the examiner places one hand behind the elbow, and an anterior and superior force is applied on the patient's elbow, while the patient tries to resist this anterior force. So that again, a pain or click in the anterior shoulder region is a positive test. Next is the bicep load test. It is again divided into two parts. One, the patient is lying in supine position. The examiner grabs the patient's wrist and elbow and abducts the arm to 90 degree with the forearm supinated. Then the examiner externally rotates the arm fully, as in the apprehension test. You can imagine the position of the apprehension test. Then we see if any apprehension is developed and the patient is resisting the attempted elbow flexion.
What happened?
So there was a power outage in hospital. The connection.
So the connection is getting cut. I'm in hospital, basically.
Okay, okay. Mr. Abdul, can you mute your mic, please, Mr. Abdul Karim? Thank you. Proceed, Govind.
Yes, sir. Next is the bicep load 2 test. In the supine position, the examiner places the patient's shoulder in 120 degrees of abduction and the elbow in 90 degrees of flexion. So the abduction range is increased and the forearm is held in supination. And then we external rotate the shoulder. So the position is almost same as the bicep load test 1, but the arm is hyper abducted. It is abducted to 120 degree and the forearm is held in the supination. Then the patient is asked to flex their elbow, and any pain shown is suggestive of a slap tear. Then the resisted supination external rotation test. The patient is lying supine on a table with the scapula near the edge of the table. And the examiner supports the affected arm at elbow and hand, and the arm is placed in 90 degrees of abduction, 70 degrees of forward flexion, and the forearm in neutral rotation. And then we external rotate the shoulder. Patient supinates the hand against resistance. So at the same position, in this position, the patient is asked to supinate the arm. So while supinating the arm, if the patient is experiencing pain or any click, then it is a positive test. No, these are these are taken from the American Academy of Orthopedic Surgeons review article published, showing the sensitivity and specificity rates of each test. So they're highly variable, except for the bicep load one test, which is having a high sensitivity and specificity up to 97%, whereas the others have a variable range of sensitivity, highly variable, and it is not very reliable. Next, coming for the biceps lesion test. Elevate the forward, flex and elevate the arm with the hand held in, elbow held in extension, and the in supination, the forearm in supination. So any pain at the bicipital long tendinous region is a positive test. And this is the Ergason test, where the patient is the arm is kept adducted and the elbow in 90 degrees of flexion. The patient is asked to supinate the forearm, and the effort of the patient to supinate is resisted, and any pain at the bicep region is a positive test. This is another test for checking a bicep lesion. This is called the uppercut test. Same as in boxing, when you are performing an uppercut, the patient is asked to do the same movement against the resistance provided by the examiner. So again, the pain at the bicep region is a positive test. This again shows the sensitivity and specificity of each test, and the most specific test is the Ergason test, and the most sensitive test is the speed test. Next, coming to test for instability, anterior and posterior instability. First is the anterior apprehension job relocation surprise test. So here what we do is we ask the patient to lie down, and then we abduct and external rotate the arm when the patient is in supine position, and then we give a posterior force on the posterior aspect. So when there is instability and when the humeral is about to dislocate, the patient feels apprehension. At that point, we do the relocation test, where we give an anterior force which is directed posteriorly to relocate the humeral head, and then the patient's apprehension comes down. Then we release the anterior force, so that's called the surprise test, when the apprehension actually comes back. So it is done at three stages. Next is the load and shift test. When the patient seated, the examiner is stands behind the patient, places one hand on the shoulder, stabilizing the scapula and the shoulder girdle, while loading the humeral head anteriorly and posteriorly, with the other hand making sure to measure the translation. So this also, this was a video. The video is not working. So on the left hand side, we can see that the patient is made to sit up. The right hand of the examiner is stabilizing the scapula, and using the left hand, the examiner loads the humerus anteriorly and posteriorly. The same test can be done in supine position also. And we note the translation. Next is the jerk test. The patient sitting, the examiner holds the patient's scapula with one hand, and the patient arm is abducted 90 degree and internal rotated 90 degree. The examiner's other hand actually loads the patient's arm at their elbow while applying horizontal adduction force. So this you can see, the patient is made to sit, the arm abducted 90 degree with the elbow flexed 90 degree, and then the patient's arm is giving we give an adduction force to the patient's arm and check for instability. These tests, the jerk test, the load and shift test, are actually for posterior instability. The anterior apprehension, job relocation, and surprise is for the anterior instability. So from load and shift, jerk test, now we come to Kim test. These three are for posterior instability, and the patient is sitting in a chair with their arm in 90 degrees of abduction. The examiner holds the patient's elbow and the lateral part of the upper arm, and then the patient, it's brought to forwards to 45 degrees of flexion, and then a posteriorly directed force is given. Check for any posterior instability. if there is pain or if there is subluxation of the humeral head, that is a positive test. This is a video, so the actual position is not seen. It is not working, sir. Next are the laxity test. First is a sulcus sign. So this is a test for generalized laxity. It indicates generalized laxity. So it is performed in two positions. One is in neutral rotation and the other in external rotation. So in the neutral rotation, the patient's arm is adducted and we pull the arm down, give an axial force downwards and look for a sulcus that is developing between the lateral edge of the acromion and the humeral head. And based on that, it is divided into three types of laxity. Type 1, there is less than 1 centimeter of the sulcus depression. Type 2, there is 1 to 2 centimeter. And type 3, there is more than 2 centimeter of the depression. And when we do it in external rotation, if there is more laxity, that is suggestive of a rotator interval laxity. So we should test this test always in two positions, in neutral and external rotation. This is a sign showing the axial pull that we are giving down and looking for a sulcus in the lateral aspect of the humeral head. Next is the Gaggis test, where the examiner's forearm pushing down firmly on the shoulder girdle. The examiner lifts the relaxed upper limb of the patient. Like this, the patient, we actually press down on the shoulder to stabilize the shoulder, and then we abduct the shoulder. We abduct, this assesses the true abduction of the glenohumeral joint without the involvement of the scapulothoracic joint. So when we are abducting more than 105 degrees of abduction, or if there is any apprehension limiting passive abduction, is considered a positive sign of inferior glenohumeral ligament involvement. Next are the drawer test. Here the patient should be completely relaxed in the supine position with like this. The patient is made to lie down like this, and the patient's arm is taken. The examiner goes in near to the axil of the patient, with the patient's arm being held in one arm. Then using the other arm, we actually stabilize the shoulder. And the anterior and posterior draw the examiner. Then for reading, in type 1, the translation is up to the glenoid rim. Type 2, it translates over the glenoid rim, and in type 3, the translation over the glenoid rim that does not spontaneously reduce. Next is the posterior draw test performed with the patient supine, the examiner holding the patient's proximal forearm while flexing the elbow to 120 degree, and the arm is in 80 to 120 degrees of abduction and 20 to 30 degrees of flexion. So this is the position of the patient when you're testing it. So we're stabilizing again the posterior shoulder, and then we will be feeling for a posterior translation using our right hand, and then holding the patient's forearm in the flexion, we'll be pushing down so that the translation we'll be checking for with our right hand. This is the slide showing the sensitivity, diagnostic accuracy of each test, and we can see that if the load and shift test has a high specificity up to 90%, and the jerk test is also highly specific with the specificity up to 98%. Next, coming to AC joint test. This I've already explained the O'Brien test. So the O'Brien test was made to differentiate between two slap lesion or the AC joint pathology. While performing the O'Brien test, if the pain is localized to the AC joint, it is indicative of the AC joint pathology. So other than that, the one more test is a cross-body adduction test. Here the arm and the elbow are extended across the chest by the examiner, and the positive test is a pain around the AC joint. Like you can see, this was a video. Again, in this position, what we do is we hold the patient, the stabilizer scapula, and then by holding the proximal forearm in the elbow, we adduct the arm to the opposite shoulder. We push the arm to the opposite shoulder and see for any pain in the AC joint. Again, the sensitive, for AC joint, the pathology, the most sensitive test is tenderness to palpation. We actually palpate on the AC joint. If it's the sensitivity is very high, but the specificity is very less. So the specificity is very much high for the O'Brien test. Next, coming to scapular-humeral rhythm or asymmetry. Normally, what happens in happens in abduction is there is a 2:1 ratio of movement between the glenohumeral joint and the scapulothoracic joint. And in overhead abduction, what happens is the humerus actually rotates posteriorly in the horizontal plane, and it rotates laterally. So the scapula rotates posteriorly and rotates laterally also while we are abducting. So this is made by a controlled movement by all the coordinated movement by all the periscapular muscles. If there is any asymmetry or any irregular firing of any of the muscles, this can lead to scapular dyskinesia. So the first is a scapular assistance test. What we do is we place our hand on the scapula of the affected side, and then we assist in the movement of the scapula. We actually help in the movement while the patient is abducting the arm, and see if there is an improvement in the abduction, improvement in the scapular symmetry. So if there is any improvement while we are actually assisting the movement of the scapula while rotating posteriorly and laterally, then it is a positive test. As the movement improves while we are stabilizing and assisting the scapula and moving. So the next is the scapular retraction test. Here what we do is we give a compression force on the medial border of the scapula. Usually what happens is the medial border actually pops out in the scapular dyskinesia. So when the scapular retraction test, what we do is we give a medial force on the we give a compression force on the medial aspect of the scapula, preventing it from popping out. And if the movement improves while we are doing that, then it is again a positive test. Next is the flip side. So the examiner provides resistance to external rotation with the arm at the side with close monitoring of the medial border of the scapula during the external rotation resistance application. If like this, the patient's arm is held at the side and the patient tries to external rotate the arm, and the examiner gives a resistance for the external rotation. And the examiner should be looking at the medial border of the scapula to see if there is any prominence that is happening. So that is called the flip sign. Take-home message, we should have a thorough physical and clinical examination for diagnosing any shoulder pathology, and no single test is definitive test. So we should always go for multiple tests and then correlate with the result and plan for and to reach a diagnosis. I had added videos for all the tests, sir, but none of the videos worked. So the tests I couldn't explain properly, sir. So thank you, sir.
That's okay. No problem. Thank you. Thank you, Govind. Thanks for explaining all the tests which are available in current literature. Problem is, we cannot be doing all these tests in one patient, because for you to present this test itself took 30 minutes. So as a clinician, you should have high index of suspicion in patients with shoulder pathology according to the age group. That's how we differentiate. There are two age groups. I'm not talking about the pediatric age group, because pediatric is variable. There is younger age group and elderly age group. Elderly age group, it is obviously understood that the most commonest pathology that the patient will be having is periarthritis or adhesive capsulitis and cuff tear. I'll come to the younger age group first and then come to the elder age group. In younger age group, that is the one which we have to focus a lot. Now, the commonest pathology in younger age group, according to the magnitude, is first one is the impingement. Impingement, and then we go to the labrum, and then we have the dislocation, that is a labral tear. Then we have lesions confined to the biceps, and the most important thing is scapular dyskinesis. Okay, so these are the four commonest pathologies which will happen in younger patients. Whenever you come across a young individual complaining of shoulder pain, which is not treated well with conservative measures, always spend a lot of time in discussing about the history. What really triggered the pain? What is the mechanism of injury? And what maneuvers he carries forward to reduce the pain? That will give you a vague idea of what pathology you're dealing with. And most commonly in younger patients, it's an intra-articular pathology. And the problem with biceps pathology or posterior labral pathology is you cannot actually pick up the pathology with just a clinical examination. You need to do some provocative maneuvers to have a high index of suspicion, and then that needs to be supplemented with adequate radiological measures. The first thing that you have to do in any patient with shoulder pathology is you have to assess the patient's scapular kinematics. Now, the problem here is
Your voice is breaking, Shah.
tend to see the scapular dyskinesisis. But I always tend now in a thin bill patient. Can you hear? Can you hear?
Oh, okay now.
Hello.
Okay now.
Yeah. Now in a thin bill patient, the scapular dyskinesis can be seen easily. Okay. But not frequently that you see thin bill patient in your OPD. So you have patients who are well adequately built with good musculature, and you have adequate adipose tissue in the posterior area aspect of the shoulder, which masks the borders of the scapula, and that's the reason why we say feel for it. And even for female patients, you have to keep your palm on the scapula medial border as well as the inferior border, and feel for the scapular prominence in case when the patient is trying to elevate the shoulder. So you have to see as well as feel. That is first thing that has to be done in young patients. Second is the mechanism of movement which provokes the pain. This is classically seen in patients with internal impingement, throwing athletes who are having glenohumeral internal rotation deficit, which can be seen when you're checking the range of motion. But to identify internal impingement, the provocative test is abducting the shoulder to 90 degrees and trying to externally rotate to 90 degrees. When you do that, it is the impingement of the posterior cuff onto the posterior-superior part of the labrum that initiates the pain, and the patient classically says the patient is having pain in the angle of the acromion or near the posterior-superior joint line. If that is positive, then you're dealing with this pathology, which has to be indicated to the radiologist when you're doing an MRI scan, because they will say in the MRI report as posterior-superior humeral head contusion. But only thing you have to intimate to the radiologist, it can be a case of internal impingement. And that prime diagnostic modality is in your hands. You have to suspect that. The next pathology is biceps. Biceps, very difficult to pick it up because you have the O'Brien test, which is considered to be very sensitive and specific, but in many cases it may not be. So we use a combination of 3 tests. One is the O'Brien's test, which should be positive. Second, is the dynamic labral shear test. That is taking the arm into 90 degrees of abduction, externally rotating it to 90 degrees abduction, and just giving an anterior shear by standing posterior to the patient. In that way, you're giving a torsional strain onto the attachment of the biceps, as well as trying to pull it. Okay. So when that happens, the patient will have pain along the anterior superior joint line. Third most important thing is direct palpation of the biceps groove. A direct palpation of biceps groove, if it is possible, and if all these 3 tests, that is dynamic labral shear test, O'Brien's test, and direct palpation of the biceps groove, if these 3 tests are positive, then you're probably dealing with a biceps pathology. Now, that pathology can be entirely confined to just the biceps, or it can be a combination of biceps along with the pulley lesion. Pulley lesion is nothing but the margins of the biceps groove, which is formed by the subscapularis or the supraspinatus. So these should be taken care of. And as I told you, the apprehension test is classical for any patients with anterior shoulder instability, but apprehension is done in 2 ways. Either the patient in lying down or supine position. Another most important is apprehension done at 90 degrees of abduction and lesser degrees of abduction. 90 degrees of abduction apprehension positive means it is mostly a labral pathology, a soft tissue pathology. Anything less than 90 degrees, maybe 45 degrees or 60 degrees of abduction, it means some amount of bony component is also involved. It can be in the form of bony Bankart lesion, or it can be a bony attrition of the glenoid. So have a high index of suspicion when you're trying to do these 2 tests. Posterior labral tear, very hard to pick up. So we need some provocative tests. You need the posterior shuck test, and then you have the Kim's test. These 2 things have to be taken into account. So whenever we are suspecting these problems, it has to be noted down in the patient's radiological request form and intimate this to the radiologist, because the radiologist may not be able to understand what you're trying to pick up. So you have to mention these things and give a clear note to the radiologist. I am suspecting a slap lesion in this patient because the clinical tests are more positive towards this diagnosis. then only you'll be able to come to a conclusion. Elderly patients, there are two problems which they have. One, it can be adhesive capsulitis or cuff tear. Also in a scenario where there is primary adhesive capsulitis with asymptomatic cuff tear. Okay. Now to pick up adhesive capsulitis, the best methodology is the history taking, presence of night pain, and presence of other comorbidities like diabetes and hypothyroidism and all these comorbidities. But the classical clinical sign is stiffness in external rotation by the side, because always, majority of the times, adhesive capsulitis actually starts from the rotator interval. So the rotator interval is composed of the superior glenohumeral ligament, which if contracted, the first loss of motion will be arm by the side, restriction on external rotation with arm by the side. So it always starts with external rotation stiffness, then followed by internal rotation stiffness, because the axillary, the anterior inferior IGHL, posterior inferior IGHL gets involved. So the internal rotation will be restricted. And the last to be restricted will be the elevation, because the patient's elevation is actually compensated by the scapulothoracic movement also. So if you are seeing a patient with normal external rotation by the side, but stiff, difficulty in elevation, then it is not adhesive capsulitis. We are probably dealing with a case of impingement syndrome or a cuff tear. So that is the way you have to diagnose. Majority of the times, patients with adhesive capsulitis also have an asymptomatic cuff tear, but we have to go as per the patient's complaint and mention that in your radiological form. In cuff tears, yes, it's clear. We have a variety of tests which are possible to diagnose the cuff. But see, supraspinatus has to be isolated when you're trying to do the clinical examination. Many people have a habit of testing for the supraspinatus with the arm in 90 degrees of abduction or elevation. That is not the way, because in 90 degrees of elevation, the deltoid has already fired and it overpowers or masks the supraspinatus. This is always positive when the anterior and posterior rotator cable is intact. That means the rotator cuff muscle will not be weak, it will be only painful, and elevation should not be a problem for the patient. And with the 90 degrees of abduction, the deltoid is already firing and maintaining the shoulder abduction. So if you try to isolate the cuff tear there, you may not be able to pick it up. So the primary movement of supraspinatus is initiating the first 15 to 30 degrees of glenohumeral abduction. So always keep the patient's arm in 30 degrees of abduction, thumb pointing downwards. That is empty can test, which will be positive. And even the champagne toes sign will also be positive. That is the way you have to pick up isolated supraspinatus deficiency or tear. Infraspinatus, very easy, because with the arm by the side, the assisted external rotation test will be positive, and then Hornblower will be positive in teres minor tear. That is all classical. But picking up a subscapularis tear is very, very difficult. Why? Because there are many other internal rotators like pectoralis major, even lat dorsi is also internal rotator. So we need a combination of tests for subscapularis, especially the bare hug. You have the modified belly press, and then you have the Gerber's lift off. Now the bare hug and modified belly press, if it is positive, it indicates that the patient's superior 1/3 of the subscapularis is compromised. That is for sure. If this in combination with the test for the biceps is positive, like the O'Brien's, dynamic labral shear, and then the direct palpation positive, then we can definitely conclude that the patient has got deficiency in the anterosuperior cuff along with biceps lesions, which can be in the form of a biceps subluxation. If the Gerber's lift-off test is positive, then it means the upper 2/3 of the cuff is the subscapularis is toned, and Gerber's lift-off test will be positive only if the patient is not having adhesive capsulitis. Because in adhesive capsulitis, patient may not be able to introrotate the shoulder. So if the Gerber's lift-off test is positive, then you can take it for granted that the patient has got a major loss in the anterior forescapula, that is the subscapularis. So try to fine-tune your clinical diagnosis with all these clinical tests that are possible, and be careful when you're trying to address a young patient with a painful shoulder. Thank you.
So the entire shoulder series that we are going to have is based on this particular session or talk that we had today. And Shyam summarized it nicely. And Govind was just reading most of the slides, which we don't want. And Govind should have come to the learning center and rehearsed it yesterday.
Sir, I am in the hospital, sir.
Huh?
I am in the hospital only, sir. The
I'm saying that you should have done it yesterday and checked.
Yes, sir.
Rehearsed it yesterday. The fellow in charge of the talks. Who's fellow in charge of the talks? Is it Praveen?
Sir, Ashik.
Ashik, your
Sir, me, sir.
responsibility.
Yes, sir.
You should have seen to it that all the videos are playing yesterday. Okay, and I request Dr. Sham to show us a 3 minutes video quickly of how he examines shoulder in the clinic. That will give us a lot of insight into the examination.
Sure, sir. I'll do it in the next Tuesday CME, sir.
Yeah, please do that.
Thank you.
And there's no reading, and then the instructions is given very clearly, Govind. You cannot read the slide. You have to understand and
Sir, I was planning to
show it on that slide.
Yes, sir. I was planning to play the video and tell that, sir.
No, I'm not talking about that. You are reading we don't want any words in the slides at all. We want only what you're digested and what you learned from this picture. You could ask one of the guys to pose for various tests. I could have taken a picture. Thank you.
Yes, sir. Thank you. Sorry, sir.
Am I audible, sir?
Start, Rohit.
Yes, sir. So today I'll be presenting the radiological evaluation of shoulder pathologies. Before that, we'll start with the X-rays. This is a normal AP X-ray of the shoulder joint. Here you can see the markings. You can see the glenohumeral joint, the coracoid, the clavicle, and the acromion. This is coming to one by one. First is the true AP, the AP view of the X-ray. The AP view of the X-ray is taken when the patient is standing straight, the collimator is placed behind, and the beam is shot directly at the shoulder joint. Here, it's a direct front-on view. Secondly is the true AP view, the Gracie view, in which here you want to see the glenoid and the preface. So there's an angulation of 40-45 degrees where the patient is made to tilt on the opposite side and stand. Now, what happens here is you get the beam of X-rays parallel to the glenoid cavity. So you see any disruptions in the glenoid contour or any defects or anything of that sort in the glenoid. Next is AP views in external rotation and internal rotation. Here the beam again, the patient is made to stand still again, and the patient's arm is first flexed, the elbow is flexed to 90 degrees and rotated externally. Then the beam is shot for external view, internally for internal view. This is used to pick up Hill-Sachs lesions or any other humeral defects in humeral head defects. Next is the scapular Y view. The scapular Y view, the patient is made to tilt and the beam is shot from a lateral position, the sagittal position. This is specifically seen or taken to see pathologies in the scapula. You'll see fractures in the scapula, translations in the scapula, any dislocations, angulations that can be picked up. Even the hooking of the acromion can be picked up to a certain extent. Next is the axial view. In the axial view now, the patient is made to sit. The collimator is placed down below in the axilla, and the beam is shot from top with an inclination of 5 to 10 degrees. This is used specifically to pick up osseous Bankart's lesions, cliff sign, or even blunted angle of the anterior glenoid. This is how it will look on X-ray. Next is when the patient is made to lie down, you have the axillary lateral view. The arm is abducted to around 90 degrees. The collimator is placed up on the shoulder and the beam is shot from down in the axilla. This is used to pick up anterior and posterior dislocations, the acromion, and the posterior lateral humeral head pathologies. Next is the West Point axillary view. Patient is made to sleep prone on the table. The arm is abducted to 90 degrees, the elbow is flexed to 90 degrees, and the elbow is hanging down. The collimator is placed up above the shoulder, and the beam is shot from down in the axilla with a 25 to 30 degree inclination. Along with this is also inclined to a 20 degrees superiorly. So this is used to detect the anterior inferior glenoid. So specifically for Bankart's. Developing view, here the patient is made to stand straight, after which the patient bends behind posteriorly, tilting. The elbow is kept in a bear hug sort of position, and the collometer is placed down and the beam is shot from top. It is used to detect axillary lateral modification when the patient is unable to abduct arm. Next is the striker notch view. In striker notch view, the patient is made to lie down supine. The arm is close to the body, is completely flexed, elbow is completely flexed again, and the hand is grasping the head. The collometer is placed behind the shoulder, and the beam is shot from top with a tilt angulation of around 10 to 15 degrees. This is used for posterior superior or posterior lateral areas of the humeral heads. Then is the supraspinatus outlet view. Here, the patient is made to stand straight. The collometer is placed at the shoulder. This is angulated at 15 degrees, and the beam is fired straight on. This is used to pick up the types of acromions. You can have the flat curved or the hooked one, and associated impingement. Next is the Sanka view. The Sanka view is specifically for the AC and the distal clavicle pathologies. Patient is made to stand straight. AP view is shot, and the collometer is placed behind the shoulder. The beam of X-rays is tilted cephalad with an angulation of 10 to 15 degrees. Here you can see the AC joint clearly visible. Next is the serendipity view. Serendipity view is when is specifically for the proximal humerus to see the sternoclavicular pathologies. Here the patient is made to lie down flat. The collometer is placed behind the sternoclavicular joint. The beam of X-ray is directed 40 to 45 degrees cephalad, and it is fired. Here you will see all the proximal clavicle pathologies. In this, you can also make out the AC and the CC joint disruptions on X-rays. This is classically done on X-rays, where you have, in type 1, you have a sprained AC, but everything else is intact. In type 2, you have a disrupted AC along with a sprained AC, and there's a less than 25% displacement of the CC. In 3, you have a 25 to 100% displacement. 4, you have everything is disrupted and the clavicle is posteriorly displaced. 5, you have more than 100% displacement, up to 300% displacement. And 6 is when the clavicle is displaced inferior to the coracoid. This is how it will look. This is a type 3 on X-ray. Next is, this is how a Bankard's lesion will look. On your left X-ray, you can clearly see the anterior inferior angle of the glenoid. There's a bony Bankard's lesion that is seen. And on the right side, you can clearly see the indentation of the humeral head. This is a Hill-Sachs lesion that is seen. This is a scapular fracture that is seen on the scapular Y view. Scapular fractures can be treated in multiple ways. You have to look into the translation, the angulation, the axillary angulation, the sagittal angulation, and the coronal angulation. Along with that, you can treat conservatively, or you need operative management. This is how a cuff tear would look. There'll be a superior migration of the humeral head, the loss of Gothic arch, and there'll be a sclerosis, subacromial sclerosis that might be noted, depending on severity and the chronicity of the cuff tear. This is an X-ray AP of the calcific tendinitis. Here you have the supraspinatus tendon that is getting attached to the GT, which is calcified. This calcific deposition is seen along the tendon, and this will cause a restriction in abduction and external rotation. This is an X-ray view of periarthritis of the shoulder, which is a most common pathology that we see in the middle age and old age group in our setting. Coming to USG, you can help. It is a very quick procedure that is non-invasive. It takes high level of skills and a long learning curve to master, but it can be a very handy procedure. It is portable, does not involve any radiation. It can detect Bankard's lesions, labral pathologies, cuff lesions, post-traumatic effusions, and dynamic imaging. Only thing is, it is very inferior to your MRIs and CTs, and it is operator dependent. Coming to CT, now as a gold standard in the assessment of bone lesions in patients with chronic shoulder instabilities, Bishop et al. Showed that CT is more reliable in assessment of glenoid bone loss than MRI or any other radiograph. So first we look into glenoid evaluation. Glenoid evaluation relies on there are multiple ways to evaluate the glenoid. We look into a few of those. One is the Pico way. So what happens here is this is normal concurrent imaging of the CT scan is taken of both the shoulders. Then of the glenoids basically. Then the affected glenoid and the non-affected glenoid are interposed. The distance between the two is measured. That is the area of defect according to the best fit circle divided by the area of the best fit circle into 100. This will give you your percentage of bone loss. The best fit circle method evaluates only the affected shoulder. So first we looked into the both sides. Now we're looking into the only affected shoulder, and is preferred method in most cases. What happens is when you have a bipolar lesion or so, then you will look into both shoulder pathologies. When it is a unipolar lesion, then the best fit circle method suffices, because when you do CT scan for both the shoulders, it unnecessarily increases the level of radiation exposure for the patient, and other unnecessary cost is also increased. Here, there is a loss of approximately 1 millimeter, which corresponds to around 4% of the area. There's Gerber's index. That's the anterior glenoid bone loss defect. Like I told you, perfect circle. The level of the distance between the diameter that is non-affected and the affected diameter. So affected upon non-affected into 100 will give you the best fit defect. Then the diameter of the affected glenoid upon the diameter of the intact glenoid. Coming to humeral head evaluation, this is specifically done for Hill-Sachs lesions. Orientation of the Hill-Sachs defect usually occurs between 6 o'clock to 8 o'clock or 9 o'clock. The mean orientation is around 8 o'clock in the intertubercular sulcus groove, which is around at 12. In vertical orientation, Hill-Sachs occurs between 0 mm and 24 mm from the top of the humeral head, whereas the bare area exists below the 19 mm. So before that, to understand this better, we'll look into the concept of engaging and non-engaging lesions. Basically, engaging lesions, the main factor in which the stability happens or there is dislocation is when there is abduction of the shoulder and external rotation of the shoulder. This puts grave tension on the anterior capsule. Along with that, it also causes grave stresses on the glenohumeral joint. The posterior part of the humerus, the humeral head, bangs on to the anterior part of the glenoid. This is the highest contact area. So to understand this better, what we had done, what the authors had done is basically they measured the glenoid index. Along with that, they measured how much percentage of the surface is always in contact with the humeral head. That came to around 83% of the glenoid surface area. So this 83% they kept as the constant minimum glenoid, minimum humeral head thickness that is required to prevent any instabilities. And now what happens is engaging lesions are those lesions which have a defect outside this 83% area. So what will happen when you apply an abduction and external rotation force, the anterior glenoid will pivot on this defect and it will cause instability or it will dislocate. Whereas less than 83% lesions will be non-engaging, where the surface area is more to overcome this defect and it will not pivot out. So this is the reason why engaging and non-engaging concept is failing, and the new concept that is on track and off track was developed. Here, like I mentioned again, the 83% of the glenoid width ensures bony stability. The area of the zone between the contact and the rim of the glenoid and the humeral head in the end region of motion, that is abduction, external rotation of the arm, is the most common region in which dislocations and instabilities take place. So a glenoid tract, that is the 83%, is measured on the posterior superior aspect of the humerus. This is the Hill-Sachs index. So that area that you can see, along with the defect, that is the G-TAF and the G-tint, that is glenoid 1 upon glenoid 2. that is measured. And in the B picture, you can clearly see the diameter, the glenoid, along with the defect. So the defect upon the original diameter, the perfect circles technique, into 100 will give you the contact area, the actual contact area. So on-track lesions are basically those lesions that are in this 83%, are in this tract. So what happens is, if the lesion is in this tract, it is stable lesion, because the glenoid and the humeral head has sufficient bone to prevent pivoting the humeral head out from the glenoid. So these are on-track lesions. Off-track lesions are those that do not have the sufficient bone stock with them, and the lesions are somewhere around out of this the area of normal pressure. So what happens is, when there is movement of external rotation abduction, this the joint pivots out, the glenoid pivots out the humeral head, and there is an dislocation or a subluxation that takes place. This normally is seen in bipolar lesions. So depending on what type of your instability you have, the Guacamo categorize patients based on bone glenoid defects and Hill-Sachs lesions engagement. So first group we classified was less than 25% of defect of the on-track Hill-Sachs. He suggested bone loss. He suggested just Bankers for them. For less than 25% with off-track, he suggested Bankers with remplissage. For more than 25%, he suggested Latarjet technique. And more than 25%, he suggested the off-track. He suggested again Latarjet technique with a bone graft or a remplissage. Coming to MRI. So MRI, this basically CT evaluates the bony structures. This will evaluate the soft tissue and ligamentous structures. This avoids any risk of exposure to radiation, whereas CT is high level of exposure to radiation. In the first film, on the left-hand side, you see the sagittal view of the shoulder joint. The second film shows the axial view, and the third film on the top shows your coronal view. You can see on this first film that the left hand side is the posterior shoulder part, and the right hand side is the anterior shoulder part. It is basically a section that takes place that is taken from lateral to anterior view, and each cross section gives you an holistic view of the entire structures present around the shoulder joint. In axial is the same again. A cross-section view is taken in a transverse position from up to down, and you can see from the whole structures in that particular section. You can see the red line crossing through that particular area. So Scotius Glyptocolis showed that MRI accuracy was only 1.3% different overall when compared to CT images, and concluded that MRI can be an accurate alternative to 3D CT imaging for measuring glenoid bone loss as well. So accuracy, the only difference is around 1 to 2%. That is why some of these newer surgeons tend to do an MRI and calculate bone loss on MRI instead of doing a CT scan. But again, to be more accurate, CT scan is the preferred method. In MRI, you can assess a few of the pathologies, like here you can see the cuff tear, you can see the tendon retraction, you can measure the distance of tendon retraction, and also measure the type of cuff tear, whether it's small, medium, large, or massive cuff tear. Slap lesions can be noted, that is superior labral anterior to posterior tear can be noted in this. Here you can see the labrum completely exposed and taken off in the right side. Next, you have the Bankers lesion. Bankers lesion is best seen on the axial view. Here, it's the anterior inferior glenoid that is lost, the labral that is torn. You can have a simple soft tissue Bankers, or you can have a bony Bankers. In a bony Bankers, along with this soft tissue labrum, you will also have a small cuff of bone torn off the glenoid. Hill-Sachs lesion is an indentation on the posterior superior aspect of the humeral head. This again happens after first incidence of shoulder instability or dislocation. You have around 60% of bone indentation seen on the posterior superior aspect of the humeral head. After subsequent dislocation, it increases to 85 to 90%. Then is your ALPSA lesion. Your ALPSA lesion is basically avulsion This happens on the, you can see, anterior surface of the glenoid. It's the periosteum and all is intact, whereas the cuff is, the labrum has come off. Along with that, you also have other lesions like the reverse Bankart lesions, the reverse Hill-Sachs lesions. So the reverse Bankart lesion takes place on the posterior glenoid, and the reverse Hill-Sachs takes place on the anterior humeral head. You have the Perthes lesion. Perthes lesion is nothing but your lesion where the shoulder, the anterior glenohumeral injury and the anterior inferior labrum is torn and lifted off the edge. Then you have the Alpsa lesion and you have the GLAD lesion. So this is, GLAD is nothing but the glenohumeral labral articular disruption. Next, this is the Perthes lesion that I was talking about. You can clearly see the anterior, superior and the inferior lesion of the glenoid that is torn off. You can see the bone, the soft tissue edema there, and you can also see a fluid effusion. Avulsion of the inferior joint capsule, that's the AIGHL Hagel lesions from scapular attachment. This is seen best on the coronal sections. Take-home message is basic radiography with at least two views. That's the orthogonal views, be it AP or lateral or whichever view you're taking, it should be orthogonal, is helpful in identifying any osseous pathologies. CT, especially with the 3D reconstruction, seems to be the golden standard for identification and quantifying bone loss. Though MRI is an upcoming modality, which is almost equivalent, but obviously not as superior to CT for assessing bone loss and defects. It is also useful in assessment of on-track and off-track lesions between Hill-Sachs and anterior glenoid bone loss. The use of MR in the evaluation of glenoid and humeral head bone loss is developing increasingly and can provide an equally accurate measurement tool. Thank you.
Thanks, Rohit. I think you've addressed all the aspects of the investigating modalities for the shoulder. I'm not going to discuss in detail about the X-ray because it is understood. You have to take mandatorily two views, either an AP and axillary or AP and outlet view, depending upon what pathology you're suspecting. If the pathology is confined to the shoulder joint in the form of a labral issues, then maybe an AP and axillary is needed. If you're suspecting impingement or any extra articular pathology, then an AP and outlet view is sufficient. The use of ultrasound has to be stressed more because it's not just for a diagnostic purpose; it's also for a therapeutic purpose. In the form of calcific tendinitis, where you have to do a barbotage and subacromial injections, or even intra-articular steroid or PRP. As a shoulder consultant, you should be able to do ultrasound of the shoulder to pick up partial cuff tears, biceps subluxations, which cannot be seen in MRI, because this ultrasound can be used as a very good tool for dynamic evaluation of the cuff as well as the elongated biceps. So that is one role of ultrasound, which cannot be replaced by any other investigating modalities. So once we finish this shoulder CME, probably in the month of Jan or Feb, we will be having a hands-on demonstration of ultrasound of the shoulder for all the fellows. So that will be very good for you. Once the ultrasound of the shoulder is not should be a part and parcel of your training, and you should be able to do it individually. CT scan, you have mentioned everything about CT, but the current literature, one more added advantage of CT of the shoulder is it is also very helpful in assessing the bone quality of the proximal humerus, that is assessing the osteoporosis of the proximal humerus. Previously, we were using the osteoporosis index for the axial skeleton like the spine, the hip, and the distal radius and the calcaneum. But not much has been spoken about the proximal humerus, and we do have an article by Pervez et al. Govind is having that article. Govind, kindly share this article of proximal humerus osteoporosis index to all the fellows, sir, as well as in the ortho-one academy, so that the members will also be able to access that. So that is another very important role of CT. MRI is the investigation of choice, but whether we have to do an MRI or MRA is the question. Now, we literally do not do MR arthrogram nowadays because the only indication for MR arthrogram is in the presence of a lax joint or in the presence of suspicious slap tear. But our radiologists are quite good enough to pick up a slab tear even with an MRI. So the only indication as such is in case of latch shoulder, that is multi-directional instability, which is mostly a clinical diagnosis. So the use of MR arthrogram is quite limited, and doing an MRI in a patient with acute traumatic shoulder condition, the blood itself acts as a medium, contrast medium, and acts as an MRI. So that is more than enough. Now, the problem that you come across as a shoulder or as an orthopedician is going just by the report, by the MRI report. Please do not make this grave mistake, because we cannot expect all the radiologists to pick up what you are suspecting. And if you go by the report, you are committing a crime. Always, clinical examination should be followed by the radiological investigation. A radiological investigation cannot overtake a perfectly done clinical examination and history taking. Now, whenever you come across a patient with bringing to you with an MRI scan showing there is something, some lesion, etc., 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 you have to first do a proper history taking, do a thorough clinical examination, and then match your finding with the radiological impression. Then only you can comment on what is the procedure of choice or what is the treatment of choice. So this is the area where all young orthopedic surgeons or even experienced orthopedic surgeons get tricked and land up in trouble. So never go by the report. And whenever you are sending any patient for any investigations to outside lab, kindly mention what all you have done in the patient, which means what are all the clinical examinations that are positive, and what is the pathology you are suspecting, and what you want the radiologist to know, so that they'll be able to pick up the pathology. So make sure that that is done mandatorily for all the patients who are sent for MRI or CT scan. Thank you.
Thanks, sir.
Yeah, one doubt regarding measurement of on-track, off-track. I mean, it's usually described in CT. Is it possible to check it in MRI?
Possible, sir. It is possible. It is possible. On-track and off-track patients, we can definitely measure it in MRI also. But the clarity of picture is much appreciated in a CT scan. MRI is good enough to assess the glenoid bone loss. It is good enough to pick up the hill sag dimension. When we know the glenoid bone loss, when we know the hill sag dimension, we can easily calculate the glenoid tract.
No, conventionally, first description, it was based on 3D CT measurement, right? On track,
yes,
off track.
Sir, 3D CT. 3D CT.
So that is on the position of that defect on
hill
the
sag. Humeral head.
Yeah, correct. But how do you see the position in MRI? Because we cannot reconstruct 3D, right? 3D in MRI.
Correct.
So how
absolutely right. So here what we have to do is we have to take the maximum width of hill sag and then extrapolate or superimpose it on the glenoid bone surface. If the hill sag dimension is more than 83% of the glenoid surface area, then it is an off-track lesion, which means it's going to engage. And that can be calculated that way. And we are doing it in the CT also that way only. The 3D CT is giving finer details of the hill sag dimension. But even with the 2D CT itself, you can easily calculate whether it's an on-track or off-track lesion. This can be used in MRI scan also. But sometimes what happens is that the bone contusion patterns and presence of fibrous tissue will mask the true dimension of the hill sag. That is where you may have some variation in the dimension. So that is the reason why we are subjecting the patient for a CT measurement.
is there any studies? If not, we can try to do a study comparing that.
I think that's a good idea, sir. We can do, sir. We can do. I'll work on it.
There is
no question. Yeah, carry on, proceed.
Okay. In today's Plasty Talk, I'll be discussing about biomechanics of knee and the design rationale of total knee arthroplasty. This is a brief overview of my presentation. I'll take 20 minutes. It's already 8:20. So, biomechanics. The biomechanics is the mechanics of a living body, especially of the forces exerted by the muscles and gravity on the skeletal structure. Biomechanics, it can be classified into statics and dynamics. And dynamics can be further classified into kinetics and kinematics. And kinematics is classified into osteokinematics and arthrokinematics. So now what is the difference between kinetics and kinematics? Kinetics, it is a study of forces that are acting on an object under a particular mechanism, while kinematics is a branch of mechanics concerned with the motion of objects without references to the forces which cause the motion. So now let's discuss about the sliding and rolling. In sliding, there is translatory movement of one surface over the other. That is, there is a change in contact surface point occurs in only one of the surfaces. But in rolling, in addition to sliding, there is rotation. So there is a difference in contact points in both the surface. While spinning, one surface spins over the other, there is no change in contact point in either of the surfaces. So that is the difference between sliding and rolling and rotation. So let's discuss about the tibiofemoral articular geometry. The articular surface of the medial condyle is 2/3 of an inch longer than the lateral condyle. There is a large anteroposterior convexity and a slight convexity in the frontal plane. And the anteroposterior convexity has a smaller radius of curvature posteriorly as shown in the figure. Now, if you notice the sagittally, the medial femoral condyle and the lateral femoral condyle, they are of different sizes and they have different radius of curvature. The medial femoral condyle, it is larger, it is more circular, and it has a uniform radius of curvature. But when it comes to the lateral femoral condyle, the circle that is red is a posterior condyle, the circle that is blue is the distal condyle. So you can make out that there's a very different radius of curvature in the lateral femoral condyle, and this promotes the lateral femoral condyle motion during the knee flexion. That is, the motion that occurs in the lateral femoral condyle in knee flexion is more than that which occurs in the medial femoral condyle. So regarding the articular geometry of the tibial condyles, the medial tibial plateau is larger than the lateral tibial plateau. The medial plateau has a convex depression, whereas the lateral has a convex surface. The tibia has a slope of 7 degrees, but the joint surface tilt is minimized to 3 degrees by the menisci. The plateau also have a 3 degree varus tilt. So if you mark the contact points of the femur on the tibia, here you can make that the medial tibial condyle is much larger than the lateral tibial condyle. So when you mark the contact points of the femur on tibia, when there is deeper flexion, the movement in the lateral condyle, it is much more than the movement that occurs in the medial condyle. So in deeper flexion, especially in activities involving squatting and all, the knee becomes a pivot joint, medial pivot joint. So let's discuss about the knee joint stabilizers. There are different knee joint has got its static stabilizers, dynamic stabilizers. Static stabilizers are basically its capsule and ligaments, and dynamic stabilizers are muscles around the knee joint. With knee flexion, the deep and superficial MCL stabilize the medial side. The LCL and popliteus tendon stabilize the lateral side. The PCL is a secondary varus and valgus stabilizing structure. And pes and serenus and IT band are parallel to the joint in flexion, so they does not give any stability in flex position. I'm just summarizing the stabilizing structures on the lateral side. The structures that stabilize the joint on the lateral side are the lateral gastrocnemius tendon, the lateral collateral ligament, the lateral posterior capsule, the popliteus tendon, and the IT band. And the main structures that stabilize on the medial side are the superficial MCL, the posterior oblique ligament, and the deep MCL. So MCL, the anterior fibers, it is slack when the knee is extended, and posterior fibers are differentially tightened in extension, and the vice versa occurs in flexion. So this is an image showing the posterior oblique ligament, the superficial MCL. So all of us know about the anterior cruciate ligament and the posterior cruciate ligament. I don't have to go into detail. Anterior cruciate ligament is a primary restraint to anterior displacement of tibia. It checks excessive medial rotation. The posterior cruciate ligament is a primary restraint to posterior displacement of tibia. It is instrumental in creating lateral rotation of the tibia, and it is critical for the locking of the knee joint. So patellofemoral mechanics. The patella, it is an anatomical eccentric pulley. It increases the lever arm of the extensor mechanism. The patellofemoral contact area changes with flexion. If you notice in the patella, it is 10 to 20 degree, it is the inferior articular surface which is articulating. 60 degree, it is a mid portion. 90 degree, the superior most portion of the patella articulates. And in deeper flexion, the more superior most portion articulates with the femoral condyles. So joint reaction forces. The joint reaction forces in tibiofemoral joint, in jogging, it is 6 times that of the body weight. So maximum joint reaction force in tibiofemoral joint is while it on running. And regarding the patellofemoral joint reaction forces, the maximum joint reaction force occurs in deep squatting, that is 20 times of that of the body weight. So regarding net knee kinematics, the knee joint has got 6 degrees of freedom. That is, movement occurs along 3 translational axes: the anteroposterior axis, the mediolateral axis, the compression and distraction, and along 3 rotational axes there. That is the flexion, external rotation, internal rotation, external rotation, varus valgus. So this was a publication which came in 2019. This is just to highlight the complexity of the knee kinematics. They found that in native knee kinematics, when on weight bearing, in deep flexion and extension, when the knee comes to the full extension to 120-degree flexion, both medial femoral condyle and lateral femoral condyle move posteriorly. And the movement in lateral femoral condyle is more than that in the medial femoral condyle. And the axis of rotation is on the medial side of the tibiofemoral joint. And beyond 120, there's posterior translation of both femoral condyle. And in the weight-bearing stance phase, both medial femoral condyle and lateral femoral condyle moved anteriorly with flexion and posteriorly with extension. And the axis of rotation is was on the lateral side of the tibiofemoral joint. And in dynamic activities involving stair climbing and running, on stair climbing, the lateral femoral condyle, both the femoral condyle moved anteriorly during extension, and the movement of the lateral femoral condyle was more than the medial femoral condyle. And on running, the movement of the medial femoral condyle was more than the lateral femoral condyle. So it is not just a medial pivot joint. The initial degrees of flexion, there's a lateral pivot. Then it becomes on deeper flexion, it is a medial pivot. And on further flexion, it is actually working like an equal pivot. So the instant axis of rotation, all of us know about the J curve. The pathway of instant rotation forms a J shape, forming posteriorly and superiorly on femoral condyle with increasing flexion. So regarding the knee kinematics, the concept of femoral rollback is the most important. When the knee rolls back, there is a combination of rolling and gliding. So you can see here that the contact point keeps changing, and this avoids the posterior impingement. So the ratio of rolling and gliding of femur and tibia increases during flexion, and it is 1:2 in the early stage of flexion, and it becomes 1:4 in the deep flexion. So regarding the tibiofemoral closed chain kinematics, that is when foot is planted on the ground, 0 to 25-degree flexion, the femur rolls over tibia posteriorly. And beyond 25-degree flexion, the rolling is accompanied by anterior glide. So this is just sufficient to create the nearly pure spin of the femur. So anterior glide, the reasons for the anterior glide are due to the tension in ACL and due to the meniscus. Tibiofemoral open chain kinematics. When we extend the knee, the initial rolling of the femoral condyle, there's the initial rolling of the femoral condyle anteriorly on tibial condyle occurs, and the lateral femoral condyle glide posteriorly to continue the extension of the femur. And the posterior glide occurs due to the tension in PCL and the wedge shape of the menisci. So regarding the locking and screw-over mechanism, on extension, as you know, there's a lateral femoral condyle is shorter, so it completes its motion early, and the medial condyle, it continued to roll and glide posteriorly. So the continued motion of the medial condyle results in medial rotation of the femur on tibia, pivoting on the fixed lateral condyle. And this is most evident in the terminal 5-degree extension as shown in this video. If you notice, at the terminal 5-degree of flexion, there is a medial rotation of the femur on tibia. So unlocking of the knee, to do flexion, knee has to be unlocked. So the medially rotated knee, it can't flex in a sagittal plane. So the lateral rotation of the femur occurs due to the muscle forces, basically the popliteus. Coming into the gait cycle, the knee, all of us know regarding the stance phase and the swing phase. During the transition from the stance phase and swing phase, there's a pre-swing and a toe-off. So this is the pre-swing and the toe-off needs around 60-degree of flexion, as shown in this 60 to 70-degree of flexion, as shown in this graph, for adequate toe clearance from the ground. So how do we design the total knee arthroplasty implants to do the same? It's very, very complicated. when you compare the native knee and the total knee, the native knee, there is a natural asymmetrical joint line. That is, the middle joint line is distal and the lateral joint line is proximal. There is a 3-degree varus in the joint line. In total knee, we are replacing this with the symmetrical components, making the joint line neutral. While what we actually want is to put in asymmetrical components and maintain the asymmetric joint line in 3-degree varus. So let's discuss about the design rationale for various designs. So when the conformity is less, there is more contact stress, there is more linear wear. And when the conformity is more, there is lower contact stress, more volumetric wear and debris formation. So as you go up the constraint ladder, the CR comes at the bottom. And as you go up, there is PS, the constraint hinge, the rotating hinge, and the simple hinge. So there are two types of wear, basically, the articular wear and the undersurface wear. Articular wear is secondary to high contact stress. It is more common, less conforming joints. Undersurface wear is between the tibial base plate and the poly. And the undersurface wear, it occurs due to the modularity in the design. So let's discuss regarding the salient points of the design elements of CR knee. In the CR knee, if you notice, the medial joint line and lateral joint line are at the same level. The inserts are flatter. There is no rollback mechanism. The rollback is brought about by the PCL, which is retained. There is no pivoting mechanism as seen in the native knee. So the advantage of the CR knee is that it preserves bone because we are retaining the CR, because we are retaining the PCL, the proprioception will be good, better, theoretically. And the problems of the CR knee includes a tight PCL, because after balancing, if the PCL is tight, there can be accelerated wear. And ruptured PCL can be a catastrophic complication and it can lead to flexion instability. And in some cases, there can be paradoxical anterior motion of the total knee. I'll come to what is paradoxical anterior motion later. So regarding posterior stabilized total knee arthroplasty, compared to CR, these are more distal insert. There's a cam and post which brings the roll back. The middle joint line is at the same level as that of the lateral joint line. There is no ACL function. The cam post substitutes the PCL. But PS knee has got its own problems. All of us know that we are removing the more bone because of the box cut. So there is, because we are removing the PCL, there is no proprioception. There is a complication of cam jump, especially when the knees lose inflection. There is a chance for post wear and fracture. And another complication is the patellar clunge syndrome because of nodule formation of the superior patellar region. And in those cases, arthroscopic debridement will be needed. So in PS knee, the paradoxical motion will be much. The fluoroscopic studies show that it is much lesser than that in the CR knee. There is more posterior contact in extension. There is definite rollback. There is no pivot. So the PSTK merits are it can be easily balanced. Exposure is easy. There is a definite rollback mechanism. Regarding anterior stabilized insert, anterior stabilized, it's also known as ultracongruent or the condyle stabilizing knee. The CR insert with the high anterior lip and the posterior lip. So we are sacrificing the PCL without a post and cam and are relying on the articular geometry of the insert alone. So kinematically, these knees are more lax. But the advantage is that it is more bone preserving, but it has got inherent problems like more wear, less range of motion. So this is a comparison of the inserts of CR knee, PS knee, and CS knee. The CR knee, as you see, it's a more flatter insert. PS knee, it is more constrained. There is a cam and post. The CS knee has got a high anterior lip and a posterior lip, which functions like the ACL and PCL. So mobile bearing total knee arthroplasty, the poly rotates on the flat tibia. So the proponents of the mobile bearing total knee arthroplasty claim that because of the uncoupling of the rotation and translation forces, because of reducing the contact forces, the wear is reduced. There are three types in terms of plateau mobility: those that offer pure rotation, those that offer AP translation, and the unconstrained design. So in vitro, these closely resemble the natural knee kinematics. The reverse axial rotation, the paradoxical anterior translation, and femoral condyle liftoff is minimalized in mobile bearing. But the problem is there is high chance because of the high chance of backside wear and bearing spin out, as seen in this X-ray. Then there is medial pivot knee. It closely resembles the native knee kinematics. The knee joint is more congruent medially, less congruent laterally. The medial joint line and lateral joint line are at different level. The ligament function is substituted with articular geometry in the insert. The kinematics, it is better because there is medial pivot in deep flexion, and studies show that it has got better potent satisfaction. Bicruciate stability, it's not available in commonly available in, it's commonly done in Japan. There's a symmetry in joint line obliquity is there. The anti can substitute the ACL and PCL. So kinematically, this has got reduced paradoxical motion. Femoral geometry, the multiple radii femoral component was introduced in 1971. So higher expectations from the patient, the concept of single radii femoral component came to the fore. But recent studies and meta-analysis show that there is no statistically significant difference between the single radius and multiple radius femoral component designs in terms of post-operative functional outcome. The attuned radius curve, there is a G curve or a gradual decreasing curve. It is there in debut attuned. The initial reports are promising. So when discussed regarding the paradoxical motion, in normal knee, there is no sliding forward or the paradoxical motion which is happening. But especially in CR knee, there is something known as a paradoxical motion, because the PCL becomes tight only in flexion. So when the patient is walking and activities that involve lesser degrees of knee flexion, there is some paradoxical motion which occurs in such designs. So how to limit the paradoxical motion? The patient tends to walk slower. They have a shortened stride length, and they spend less time in the stand space. So PS knee, because the cam post engagement occurs in the 15 to 60 degree, the paradoxical motion in the PS knee is much less. And these patients, they complain of like a feeling of walking on ice, difficulty in getting out of chair, difficulty in ascending and especially descending stairs, difficulty in walking on uneven ground, etc. But after some time, they get used to that. In the normal knee, if you compare the translation of the normal knee and total knee arthroplasty, the AP translation, the translation lateral condyle, the medial condyle, everything, it is much lesser than that in the normal knee. AP translation normally it is 16 mm, in total knee it is 6 mm, lateral condyle it is 6 mm, total knee it is 2 mm in lateral condyle. So the axial rotation at 90 degree flexion is 80 degree normal knee as per the fluoroscopic studies, and the axial rotation of 90 degree flexion is -5 degree to, that is 27 degree to -20 degree. That is a reverse rotation is happening in total knee arthroplasty. So the take-home points from my presentation is that biochemical principles are the key elements to design a processes. Knee has very complex kinematics, and it is difficult to recreate native joint kinematics by total knee arthroplasty. The key design elements in total knee arthroplasty rely on articular geometry and substituting function of PCL and ACL. Each design has its merits and demerits, but after all this, 90% of the patients are satisfied with their results after total knee arthroplasty. Thank you.
Dr. Yuvraj?
I think Yuvraj is gone. Dr. Santosh there, Shyam? All
Yeah,
gone.
I'm here. Okay, thank you, Arjun. It is the same presentation, mostly
Hello.
same which Dr. Yuvraj had given in the meeting on Sunday. Am I right, Arjun?
Yes, sir. Yes, sir.
Yeah. So, thank you, Arjun.
Okay.
All right.
So I think you're
Yeah. Arjun, am I audible?
Yes, sir. Yes, sir.
Any points to that,
Sorry,
please?
sorry, I will disconnect my. It's a good presentation, but only thing is alignment concept you have to highlight, in your basic biomechanics. There's alignment principle you have to understand when you're restoring the joint principles and kinematics. But still in 2023, we don't know which design is recreating the native kinematics. That is really a challenging one. And even in 2023 also, they come up with recently it is published in Journal of Arthroplasty, compartmental specific replacement. They are doing a patellofemoral plus medial femoral condyle or combination of lateral femoral condyle with patellofemoral. So they want to recreate the native kinematics, but still the design aspect is still evolving, but not much changes has happened. They're based on the principles from the Freeman as well as by the Insol's principles. But the finer kinematics, still we are targeting for this 10 to 15% of dissatisfaction group. That depends on the surgeon's preference. So that's what in my talk also I was highlighting. The implant of choice you should choose based on the track record or scientific evidence, and based on your clinical evidence, and that is very important. And the available implants are really good now with the good kinematics. But the only thing is the choice versus a CR or PS, or you're going with a partial knee and a CR knee, and it depends on the surgeon choice. But you should have a basic knowledge about which knee works very well and how we have to recreate for the particular patient. That's it. So otherwise, this is a very extensive topic. Still, we can discuss for next 1 hour. But pertaining to the topic, we covered everything. You covered everything. Good. Thank you. Thank you.
Thank you, sir.
Thank you.
Thank you, Dr. Vilas. So,
Thank you so much.
we'll end the meeting.